Good afternoon, everyone, and welcome to the WEDI Member Position Advisory. Today, of course, on the CMS Notice of Proposed Rulemaking on Advancing Interoperability. I just wanted to add my welcome as we get a few more people online. And then I'm sharing the introductions with the chair of WEDI, Ed Hafner, and my colleague, Rob Tennant, who's going to be very active this afternoon, who is the Vice President of Federal Affairs at WEDI. So today's agenda, as you will see, we're going to spend only a few minutes in the introduction and outline of the MPA process. And then hopefully around 2:10, we're going to have a discussion of the NPRM by Ed Hafner, the chair of WEDI, Bob Dieterle, who is HL7 Da Vinci Project and Enable Care Group, as well as Rob Tennant again. And then we hope to wrap up around 3:45. We will have our wrap up, and that will be Ed Hafner and Rob Tennant. So I will now turn it over to my colleagues. Ed, are you on? Oh, there you are. Okay.
Hi, Charles. Hello.
Hello, everyone.
Yeah, welcome. We have a really nice crowd for our member policy advisory discussion on interoperability today. And like most of our meetings, we start off with just a little bit of background on WEDI. Just go take a few moments just to make sure everybody kind of has a perspective of who we are. We were established in 1991, 32 years ago, Charles, by Dr. Lewis Sullivan, who was the HHS secretary at the time. We're named in law by the HIPAA legislation that came across as an advisor to the Secretary of Health and Human Services. If you've been working with us through a number of years, you can tell that we've had all kinds of cool relationships with people in Health and Human Services, including CMS, Office of Civil Rights, the Office of National Coordinator, but also other areas as well. We're expanding our reach, for example, like CMS Innovation and other areas. We are unique and take pride. We have health plans, providers, vendors, software development organizations, state and federal government officials, a number of associations that are that many of you are use on a daily basis, their names. And we work together to try to better healthcare. And so I think we're a very unique organization that does that. We have many educational programs. We also have 18 focus work groups and task groups. And you'll, of course, our role is to convene, collaborate, educate, influence, and of course, and advise. You'll see at the very top, HCEG helped put some of our survey stuff together, and we're nice partners with them. So we welcome them and their participation in these events as well. Next slide. The member position advisory process, I gotta get that acronym right, Charles. It was actually developed by our policy committee, chaired by Bob Bowman and Jay Eisenstock. Nancy Spector, who was our recent past chair, also was very involved with that. And it really modernized how we provide input to Health and Human Services. Previously, you may have heard the PAG, or Policy Advisory Group. If you participate in that, you'll remember your company got a colored paddle and you'd raise your hands to vote. You had to be in person for the most part. And it was a very formal process, but we've learned a lot from virtual meetings and having discussions and allowing people to emote their feelings, and whether it be about their passions towards healthcare or whether their passions about the organization. Of course, the MPA was approved by the WEDI Board of Directors. And at the end of the day, it's such a wonderful tool. We've been using it for like topical issues, public and private sector proposals, even when we were actually given some thoughts from, for example, CMS to be able to get input from our membership. We can use it for that. And of course, reviewing things like government proposed regulations that we're doing today. You'll notice that we do collect information ahead of time for these events. We typically do surveys, but we also can do interviews face-to-face. And of course, we can do these virtual events. I would like to ask you something, and you'll see my passion over the next 2 years. I really, truly believe WEDI is in a position to make a difference for U.S. healthcare. And you are participating in that. I want you to feel it. I want you not to be shy. I want you to be able to raise your hands in a very safe environment, to be able to have discussions. If you don't know things, just ask us. And we'll be very gentle to correct you if something's not quite right, but it's a great place to learn and to participate and to grow not only your career, but an altruistic perspective, actually being able to better people in the United States experiences with our healthcare system. Okay, so that's your pep talk. So at the end of the day, today, we're going to be using this input. It's recorded, and Rob takes these recorded sessions very seriously to help create the official WEDI response, where we will be advising Health and Human Services with our perspectives today. We like to have it nice and balanced. And hey, gosh, if we do contradict each other, that's okay. We could document that, right, Rob? And so that's that's very important to note, right? So if we don't all agree, that's one thing. But don't just talk about it from your perspective. The company's perspective, also talk about it, about advancing healthcare. And typically, we do have some people from the government that actually listen to these recordings as well as attend these recordings. So we have certainly have the ear of Health and Human Services. And Rob, I'll turn it to you.
No better way to get this going, Ed. Thank you so much for that. And thank you, Charles. Let me add my welcome. Next slide, please, Michael. And just to give you a glimpse into why we're holding this. Most of you, of course, already know this, but back in December 13th, CMS published a notice of proposed rulemaking. I won't read the long title. The short title for purposes of today is Advancing Interoperability, which is what we're going to focus on. Comments are due to CMS the middle of next month. And so this, again, is a wonderful opportunity for us to gather critical information about these rules and share it with the government. Of course, there's no timeline for a final rule. Things could come later this year or perhaps next year, but we know that they take comments from the industry very seriously, and in particular from WEDI, because we do represent most of the major stakeholders in healthcare. And when we issue a recommendation, it is consensus-based. So it's very helpful for the government to hear perspectives from sort of the industry rather than just hearing from specific stakeholder groups. Next slide, please. As Ed said, again, do not be shy. This is your opportunity to share your perspectives, to ask questions. We are really delighted to have Ed, who is a real expert in this area, as well as Bob Dieterle, who is a renowned national expert on all things fire and API. So he is here to help, to facilitate, and also to answer any questions you have from the technical perspective. We do ask that if you want to discuss something, you can please raise your hand and then we'll call on you. You also have the ability to type into the chat. We capture all of the chat. So if you want to make a comment but don't want to say it orally, please put it in the chat and we will be able to review it after the program. We also may use that in our dialogue as well. We'll monitor the chat as we go forward. As always, the slides and recording will be emailed to you following the event. So it'll be your opportunity to get a second look at the materials. Next slide. So with that, we'll jump into the vision of the Centers for Medicare and Medicaid Services. Next slide. Most importantly, CMS in this rule rescinds their previous rule. And so they say after considering stakeholder concerns about implementing the payer-to-payer data exchange requirement finalized in the December 10th, 2021 rule, in this proposal, we are proposing to rescind our previous payer-to-payer data exchange requirements and replace them with the new policy. Of course, we'll be discussing some of those new policies today. Next slide. So their new approach, they say we are now proposing to apply our newly proposed payer-to-payer API requirements to Medicaid and CHIP fee-for-service programs, in addition to other impacted payers. The new proposed policy would require impacted payers to build a payer-to-payer API to facilitate the exchange of patient information between payers, both at the patient's request and at the start of coverage with a new payer. Specifically, the data exchange would include all data classes and data elements, including in the standard already adopted, which is the US CDI version 1, would also include adjudicated claims and encounter data, not including, of course, remittances and enrollee cost sharing information and the patient's prior authorization decisions. They've asked for comments on a lot of this, which we'll go through over the next hour and a half or so. Next slide. So the first question we'll ask, and we are going to ask you a lot of poll questions, and it helps us understand your perspectives on the rule. But first of all, we're interested to see how many folks have a good understanding of what is in the rule and how many are coming in not quite as knowledgeable. So we can see here, most of the folks have had a good long look at the rule. We'll leave it open for just a couple more seconds. And again, I would encourage you to please vote. It absolutely helps us. And we do capture all of the polling information following the event, and we can use that in our comment letter to the government as well. So it looks like most of the folks are very knowledgeable or somewhat knowledgeable. A few folks are not quite there yet, but hopefully after this event, you'll know even more about the rule. So I think we can close that, Michael. So we'll skip into now, of course, there's a number of interoperability components of the rule. We're going to talk first about the payer-to-payer API. And if we go to the next slide, rid of that one. So there we go. So maybe I'll turn to Bob to introduce the payer-to-payer fire exchange.
Thank you, Rob. What they have chosen to do in this proposed rule is to take advantage of business-to-business exchanges using FHIR. So this is really a B2B process. What it allows a member to do when enrolling in a new plan is to go and indicate to that new plan that they wish to have their information from a prior plan pulled forward and made part of the medical record. That election is conveyed using the PDEX implementation guide, or can be conveyed using the PDEX implementation guide, payer-to-payer exchange. Part of that capability is to go and establish trust between two payers, to go and identify a unique shared member, and then to go and request the data that exists on that member from the prior plan and bring it forward. They're proposing that the deadline on this will be 1/1/26. It uses a method, like I said, that's different than the patient access API. It now uses a pure payer-to-payer exchange. Questions?
So what are the thoughts, in particular from our health plan folks in the audience? Obviously, this is not a new concept for you. Is there anything in what Bob described that would cause you angst, or if you believe there would be significant challenges that we would need to raise? Okay, so Benji writes, endpoint discovery is one of the larger issues. I don't know, Bob, if they don't talk too much about endpoints in the rule.
No, the implementation guide, though, does talk about endpoint discovery. It recognizes that in the future, you'll be able to use, assuming we move forward with the national directory to discover endpoints. In the interim, there is a process described in the implementation guide that allows each of the impacted payers to go and publish its endpoint in an open repository that the other payers can then pull down and use that information, which would have been digitally signed by that payer, to go and populate their own payer-to-payer directory. So the goal is not to have to go out and have 360 payers talk to each other separately, but rather to have them all deposit things in one place and make it available to each of them that are participating.
So, Bob, it looks like there's two options, right? There's the have an endpoint directory and allow the payers to interact. But what you're saying is almost like a hub approach, where payers would go to one hub in order to exchange?
Well, we recognize that the national directory may not be in place before this rule takes effect, is what we're doing. And what we're doing is providing an interim solution where in an open shared directory, payers can post their endpoints and retrieve other payers' endpoints. That's not a long-term solution. That's an interim until the national directory is available. Once the national directory is available, then that would contain the payer-to-payer endpoints for all payers, along with other things like the prior authorization endpoint or the patient access API endpoint. Okay, so the intent is the national directory will have all of the endpoints that are relevant. Question is, when will it be available?
And who would be responsible for developing it? Is that potentially a WEDI comment to say, the government needs not only to endorse this, but potentially fund it as well? Because if it's not in place, Bob, what I'm hearing is it's not going to be easy for health plans to achieve success here. Is that fair?
That's very fair. And in fact, in the RFI that CMS put out regarding a national directory for healthcare and services, they asked the question, should CMS be responsible for creating that? And most of the responders back indicated they believe they should.
Yeah, including WEDI. Yes, exactly. But I think it's worth us making a comment in that direction to remind them that, in order to have success here, it's going to be up to CMS to develop this, and frankly, to develop it well in advance, I would think, of 2026, correct? So it's live and it can be tested prior to the compliance date?
We'd love to see that. The question is, when you go through the normal authorization, procurement, development, deployment cycle, that may or may not be possible. And what we're doing is we're creating an alternative in the event that doesn't happen before 1/1/26. But yes, we would love it to happen well in advance.
And then Chris asks, will the directory be mandatory? If not, it will only help a little. A very good point, I think. Just looking through some of the chat. Brian writes, as organizations adopt use of the QHINs via TEFCA, some of these connection issues will be solved. I think I agree with that. I'm not sure all issues will be solved, though. Janice writes, and QHINs TEFCA have, she points out correctly, have currently no fire requirements. We do know that there's a fire roadmap as well. Ed? Yep.
Yes, Rob, first of all, I want to encourage everybody to raise their hand and talk if you're not shy, because hearing you talk all the whole time is going to be making us go to sleep. So we want to hear other voices. I'm kidding. But hey, Bob, something that's bothered me when I read the rule, and, they strongly recommended, some of the Da Vinci, implementation guides. And if you're not requiring them, or people are not implementing them fully, I'm afraid that some of the integrations between each other are going to be pretty hard. And I'd like to open up discussions on being able to, because I think that's something we should really comment on and hear what everybody thinks.
Yeah, and I see Mike. We'll go Mike first, and then Janice.
Yeah, I mean, I think that Janice was kind of hinting at, the interoperability standards for APIs are required, meaning the HL7 FHIR release 4.0.1 is named, as well as the US Core Implementation Guide, the Smart Application Launch Framework Implementation Guide, and the OpenID Connect Core 1.0. Those are the standards that are required in this NPRM, or proposed to be required, but the implementation guides are all recommended.
Huge issue. Janice? Oh, she put her hand down. Okay. I think we can
I didn't have permission to unmute. I put my hand down.
Sorry. Oh, please go ahead. Okay, good.
I apologize. I was basically planning to make some of those same points. I believe that the lack of requirements for using specific implementation guides is going to be a problem. The idea is to have standards, and having just sort of these vague concepts of you have to do it kind of sort of this way is not really going to be helpful or to meet that requirement.
Yeah, the rule uses the word a lot. They use the word encourage, which is never a good thing when it comes to move the industry forward. I don't know, Bob, if you have some thoughts on the type of language we might consider including in our comments in regards to the IGs?
The problem that CMS has to deal with right now is these IGs are going through a second round of publication, and we need the ability in the future to go and update these versions without running into some of the complexities that we've seen through things like HIPAA defined transactions. So there is, as far as we can tell, work going on between CMS and ONC to look at certification criteria for these various types of exchanges, in particular prior authorization. To the extent that ONC, and there is a regulatory agenda item for this, chooses to go and certify, then they can adopt the implementation guides and they can use the SVAP process, which they have, which is a sub-regulatory process to adopt future compatible versions. That's probably the most preferable approach, rather than adopting a single version into regulation, which then would have to have it changed by issuing a new regulation.
Yeah, good point. Janice?
Yes, this is Janice Karen from the Massachusetts Health Data Consortium again. The problem with the SVAP process, I agree with you in theory, but the problem is, again, if the goal is to be standardized and to have everyone consistently doing the same thing, then allowing people to be using multiple versions doesn't really meet that requirement, because you don't know, there are incompatibilities. There's no requirement that different versions of things be backwards compatible at the moment. And if you have to, so that means that if you want to support all of your partners, you have to support everything.
Under SVAP, there is a backward compatibility requirement. Whether that has been fully implemented as part of the process by ONC is a slightly different question.
Before we go to Chris, let me float an idea, and maybe we'll have a show of hands if you agree or not. But there's been discussion in particular with X12 because they're running into the same issues in regards to versions being named in regulation that may be outdated by the time the final rule comes out. The idea is it possible to either identify the latest version of the IG in the final rule, or reference that the most current version of the rule will be adopted once the rule goes into effect? So that's an option, but let's go to Chris and then Mike.
Hi, this is Christopher with Independent Health. One of the challenges I see with the way this is being approached is that we as payers are expected to build these APIs to certain standards. The standards are individually named, any one of which could move on their own. So like there's possibility of NPRM on moving up the US CDI. So even though it references version 1 in here, it's whatever happens to be in play at the time it is applied. And as these individual standards are advanced or modified, then the APIs need to be modified to stay in alignment with that. Unlike where with say the X12 named guides, there isn't a regulation that says, okay, the standard points to 5010. The thing points to the guide which references to a specific thing. So there can be a challenge if you have pointed to name standards that could move independently, that you're going to have to keep modifying your API to then keep up with whatever these independently named standards are.
Appreciate that, Chris. Mike?
Oh, yeah. So yeah, I just wanted to elaborate on what Bob had said about these updated versions of standards, and kind of also speak to what Chris was talking about. There are allowances to allow those impacted payers called out in the NPRM to use updated versions. And it's codified as using the updated version of the standard, implementation guide, or specification does not disrupt an end user's ability to access the data described through the required APIs. So there are allowances to use updated versions that are codified in this NPRM as long as it does not disrupt the end user's ability to access the data.
All right, any last thoughts on this particular issue before we go forward? All right, Michael, I think we go to the next slide. So I'll take that one on. So under the peer-to-peer data exchange proposal, CMS is suggesting that prior authorization information be included as part of the patient's longitudinal record received from the previous payer. The prior auth information would thus be available for consideration as part of the patient's historical record. So that is a change. So I'm interested to hear from folks if that would be a challenge. Maybe I'll ask you, Ed, first, with your knowledge of the payer community. Is this going to be an easy task for the plans to be able to capture and report this data?
Yeah, let me, I knew you're going to surprise me today, Rob. So we're talking about prior authorization information being included in the longitudinal information from previous payer. Yeah, there's certainly some benefit here, right? Where if there was a prior authorization that's in progress or was recently approved, that would be something that would be very helpful to the to the new health plan, as well as, of course, the patient who needs that procedure done. That continuity of getting that approval and process and all is very important. I'd be interested in hearing from payers the impact to them. I mean, my goodness, each payer has their own medical policies, and how are they held to someone else's health plans making those decisions. And it's a pretty spicy question you have here. So I'll defer to health plans and see what they say.
Yeah, so if you want to raise your hand or put a comment in, I will say this general issue was included in the consensus agreement put together back in 2018 from the AHIP Blues, AMA, the pharmacists, AHA, and MGMA way back in the day now, but they did recognize that it was important for continuity of care for if the patient had been successful on one drug, for example, not to have to go back and take a drug that didn't work before because they changed health plans. But maybe I'll pick on some folks, Marilee or Chris. Any thoughts on how challenging it would be to capture and share this type of PA data? All right. Okay, Janice. Yep.
All right. Yeah, I wanted to give the actual payers a chance to comment first since you were asking them, but since no one else spoke up. One of the things that we've heard concern about is actually the specific data requirement to include all of the data that was used in making the determination, regardless of, that's a huge scope of data, and some of that may not have come through via FHIR already, and to turn all of that around in a day or 3 days, or I think it's a day if I remember correctly, for the payer for that it has to be in there within a day is a really big ask, especially when some of that may have to be mapped to FHIR, or again, may not be data. You may even have to create your own resources to deal with it if it's not stuff that's commonly exchanged via FHIR or stored via FHIR.
Yeah, go to Chuck and then Benji.
Hello, Chuck Favorka, Kunstler and Associates supporting Michigan Medicaid. We've had a discussion actually this morning on the issue of whether we would, our prior auth team would be willing to accept a previous payer's decision regarding a prior authorization request. And that is very problematic in our environment. We also considered, for example, exchange of PA data between certain major carriers within Michigan. And of course, that's our focus. And we believe that there would be difficulty recognizing the differences between, for example, the commercial payers acceptance and the Medicaid or other affected payer under this regulation. So my question in the chat was, are we talking about carrying forward the treatment history only at this point, or are we talking about carrying forward and honoring the prior payer's decision on a PA request?
If I recall correctly, the rule asks that question. And so I know I've put it in the slide deck for next Tuesday, but we can talk about it here because it's two separate things, Chuck. I think you're absolutely right. It's one thing to share the information. It's another for the receiving payer who has now taken responsibility for that patient to say, okay, we're not going to require a PA for that. So we'll go first to Benji, but then if go ahead, Chuck.
If I might follow up, Rob, one of the thoughts that we were kicking around was whether we could receive in that data transfer regarding previously approved PAs an actual essentially 278 request that we could roll into our work queue so that it would contribute to a reduction in burden on the patient and on the provider, where the PA would not have to be re-entered, that it would be exchanged electronically, but be viewed as a new request by the new payer.
Good point, Chuck. I think we can go Benji and then Ed.
Hey, thank you very much. This is Benji with HCSC. I think really good points raised by Chuck, but I think one of my biggest concerns is, you know, at this point, there's an extreme lack of maturity around even the PDEX profile, right, which was sort of newly spun up in light of this NPRM to handle passing prior auth decision data, right, through the explanation of benefits resource. I feel like we'd want to have a lot heavier vetting with interested parties in kind of the utilization management and prior auth space to make sure that that resource is sufficient for passing that information around, right? And I think Bob in the chat correctly noted that this is an expectation for both the patient access, the provider access API, and the payer-to-payer API that we make this data available. But I'm concerned about suitability of the, you know, the current profiling that's been done. That's what I've got.
And Benji, let me keep you for a second. You and others, how would you feel if WEDI were to say something like, we understand the value of this, but we recommend that CMS closely monitor the ability of the industry to meet these requirements following the compliance date, because there is the potential, if things aren't working, potentially they might modify the rule.
Well, and let's think as well, like I'd like more clarity around exactly which data points they want captured in that resource, right? Whenever we make those resources available to payers, providers, patients, what data points are they wanting to be captured? Is it just, yes, it was accepted and here's the date range, or, you know, no, it wasn't authorized and here's the denial reason, or is there more to it than that, right? And I think that's where it probably needs some vetting, and maybe WEDI can comment to that, right? That perhaps we need more vetting around the usefulness, because to Chuck's point, if the point is that if someone has a treatment authorization in place when they switch provider or when they switch payers, it's going to be difficult for us as a payer to accept that and enforce that, because we don't know if it met our medical policy standard. And so even if in some case where you have workflow that spins up a new prior auth request, well, we'd have to re-request all of the medical attachments, right? All of the medical records that went into making that decision. So I don't know that we've effectively reduced that burden. And I don't know that that's really a use case that we're ready for long term, you know, as we get into automation and automated interoperability between payers and providers. I think we can get there, right, to where this would be something acceptable, because we'd be interoperable with that prior payer and we could grab, you know, some additional information. But I don't think we're there yet, and I don't think this NPRM gets us to that point either.
Appreciate that, Benji. We've got Ed, then Sam, and then Denny.
All right, thanks, Rob. Kind of going back to where Chuck was at, and you know, it's kind of two-sided, right? So if you imagine yourself as a patient and you get approval for something that's really, you know, painful, and you know, you've got approval to move forward with your doctor, you know, there's obviously a time frame to those prior auth approvals, and there's also an element of who's in network and who's not, right? And then I believe, if I remember the rule correctly, and it's been a while since I've read it, it's like a whole year's worth of history of what's been approved and anything that's currently being pended, right, or currently being denied. I think that information is being sent over to the other health plans. So if the other health plan has, I certainly understand Chuck's position of, gosh, I need to really evaluate this decision of another health plan that they made. On the other hand, the patient, or, you know, has already gotten acceptance and ready to move forward with the procedure, and they're right in the middle of changing plans. So I think it's important to note that there's a patient impact either way.
Great point, Ed. Sam, nice to see you. Please go ahead.
Hi, everybody. Sam Rubenstein from Montefiore Health System. I am sitting here listening to this discussion and, wondering, to continue what was just being said about the patient's perspective on this, which also, incidentally, is a reflection of the doctor's position on this, because if you keep saying that, and which is a lot of this happens in today's world, that you have a change of insurance payer and the new payer rarely, if ever, accepts the authorization from the other insurance carrier, but they will respect the medical decisions that were made from the perspective. If you have somebody that started on a chemotherapy regimen, then they're halfway through. And just because the patient's insurance changed, the physician's not going to be too happy about having to say, okay, I'm going to change my course of treatment because, the patient's insurance changed. That doesn't happen either. So I think that there's a lot, you have to take a step back and say, what are the exact usages that this is going to bring to the industry? Because the other piece of this that comes to mind is that we constantly have situations where we don't find out about the patient's insurance until way after they've been treated. And at that point, when you have that, is there still a need for the data? Is the the interoperability devalued, and we have to still share, because that is a big problem. And as somebody said, the authorization component includes everything that was used during the decision-making process, which could include X-ray films. It could include, test results. It could include a whole bunch of, data that's so it's that identifying the real use cases of these the need is really going to drive what you need to exchange and how it should be protected.
Excellent point, Sam. And maybe one perspective here is, I think you alluded to it, Sam, the real benefit for this movement of data, and Bob said it in the chat, is the payer-to-patient API, because there's some real action that can be taken, and it arms the patient with more information. But as we've seen in the chat and from folks like Benji, when the information is flowing from payer to payer, they have different policies. And unless the government were to step in and say, payer, the new payer, you have to accept the decision from the previous one, unless they do that, the question is it a good use case? And I'm hearing that it may not be the best. But with that, we'll go Denny and then Janice.
Thanks,
Denny.
Rob. I'm Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium and a proud member of the WEDI Board of Directors. A couple of things I think we need to consider as we look at the complexity of payer-to-payer exchange, payer to patient, provider to patient, all of the APIs that are being considered here, is that we often look for the technological solution to some issues that may not best be addressed in that fashion. For example, over 40 states in the US are now considering and undertaking prior authorization reform and are likely to move at a faster pace than the federal regulations. One thing that these state-based initiatives, among the things that these state-based initiatives have in common are, one, increased transparency around the prior authorization process, comparing approvals and denials across plans, for example, that EPA be implemented, but not necessarily in the fashion that is recognized or supported through Da Vinci and FHIR-related implementation guides. 3, that prior auth be expedited. 4, that there are laws that are being passed that are saying there's a bolus of clinical services that if they require prior auth, the prior auth should be the same across different health plans. And lastly, understanding that, you know, a number of states are conducting reviews of insurance company prior authorization practices to be sure they're in compliance. So my point is, we can wrestle a number of these challenges to the ground technologically, but as an organization, I think it's important for us to understand what's happening at the state level and to recognize that there's a considerable push to change the fundamental nature of prior authorization beyond automation. And keeping an eye on that, I think, would put us in a better position to respond to a number of the challenges that are forthcoming. Thank you.
Excellent points, Danny. Janice?
I'm not saying this just to suck up to my boss, I promise. Denny said most of what I was planning to say, but one further clarification, which is that in addition to standard services, I know Massachusetts in particular is looking at standardized forms, standardized data required for certain subsets of services. And so that may be a way to, for things that are fairly common where there might be some level of agreement, having that be part of the process might alleviate some of the concerns that have been raised under this section.
And so those are state-specific requirements, correct, Janice? Okay.
And they're not actually in place yet. They're in process, but that might be a way that CMS could adopt some of those types of approaches nationally to address these types of issues.
Yeah, and before we go to Bob, I will say that we are looking in particular at our spring conference and through our podcast to identify some of these innovative state level approaches, and Denny is one of those we've tapped to talk about what's happening in Massachusetts. So keep your eyes on our conferences and our podcast for that. But Bob, please.
Yeah, I think the last several commenters have raised some very good points. I would suggest that what CMS is proposing for a technical process to exchange information between payers and members, payers and providers, payers and payers, doesn't prohibit anything that we're talking about as far as standardization at the state level. It provides a standard way of exchanging that information once it's been agreed to. So I think these are complementary solutions, not divisive solutions.
Great. Michael, I think we can go to the next slide. I think we might have a poll here. Yeah, we do. So we've had a lot of discussion, so I'm interested to see your level of agreement. Payers should be required to include prior authorization information as part of the patient's longitudinal record received from the previous payer. So please share your opinions. We had a very interesting discussion around this. And again, that's not to say that if you say no here, that's not to say it shouldn't be included in the payer to patient API. So it looks like general agreement. A few, we'll give it maybe another 5 seconds here to vote. And we'll give Celine the last word on this. Again, yeah, good point, Celine, talking about that it should be adhered to by the new health plan. So, okay, I think we can end the poll, and looks like generally supportive. I think there's some that disagree, so we'll keep that in mind. So thank you for sharing your perspectives. I think we can go to the next slide, Michael. So a big issue included in the rule is the patient opt-in, opt-out process. So they are suggesting an opt-in process for gathering patient permission for payer-to-payer data exchange. So they're really asking, are there any barriers to interoperability with an opt-in approach? Of course, anytime you do an opt-in approach, you're going to limit the number of patients that are impacted. But other thoughts, again, from in particular the payers or those that help payers, anything in terms of policy approaches or technical requirements that could provide all impacted payers with the assurance that they have gathered the appropriate permissions from patients. Anytime you're getting an opt-in process, it's challenging. So we'll open it up. Anybody have thoughts on this?
I beat you to the punch now this time, Rob. It's you're looking at a couple of issues, right? There's an educational perspective of how many people are actually using their apps, and how useful is it? And if we're going to have a huge overhead moving all this data around, and people don't know about these apps, or maybe perhaps aren't enabled to use those kind of apps, I think that's an overhead that perhaps is maybe too much. And perhaps as we have more of a computer literate aging process going on, then perhaps maybe we want to change that perspective. That's my take on it. I think it's just way too much to do it for everybody.
Well, and there is the old, if they build it, will they come? And they haven't so far. I think we've heard from a number of commercial plans, virtually all of them offer apps now. They aren't being utilized to the extent I think that some would have hoped. So Ed, I hear you correctly that perhaps a WEDI comment might be along the lines of CMS, this is a public good, potentially a public utility. You need to educate patients regarding their ability to take advantage of this unique opportunity to get their health information. Is that fair?
Yeah, I think it's very fair. And I think there's an underlying perspective. Is it up to the Medicaid, Medicare Advantage, CHIP, federal exchange organization do that education, or is it up to the, Medicare CMS to do it? And, I hear that that's kind of a heavy burden on the health plan side.
Gotcha. We'll go, Jan. Oh, go ahead, Ed. Sorry. Okay. We'll go Janice, then Marilee, and then Bob. Janice?
So I would have a different answer to this for the other APIs, but for the payer-to-payer API, there's almost no choice other than to do it as an opt-in process, because you need the information from the patient about their previous insurance. Because there's no, the new payer, unless you're changing plans within the same payer, in which case I would consider that a different case because they probably already have your data. But if you're changing from one payer to another, then in order to be able to access the old data, you need to have the information from the patient. So I don't see how you could do it without having the patient opt in. Even if you don't have a box that says opt in, they have to supply you with the information or it's not going to happen.
Great point, Janice. And the other issue is, of course, the patients now have the right not to have their insurance have certain information. For example, if they decide to self-pay for a test. And I guess you could argue the same might apply here, that they should be allowed to decide what the new health plan receives in terms of information. But you're right, I think from a practical perspective, and maybe Marilee can provide some insight here, an opt-out process might be extremely challenging. Marilee?
I don't have any pearls of wisdom on difficulty comparing opt-in to opt-out. But what I wanted to touch on myself was something that Ed said, building on something that Ed said about education and getting a clear understanding for the patient, not only that they have the ability to opt in, opt out, whichever way we do it, but also understanding how the data would be used. Because I think that in today's world, we're all afraid of our personal data being shared. It, to some extent or another, it's a big fear because of the bad guys out there that do bad things with your information. And I think that there's going to be a pretty significant chunk of the population that's going to hear, you're sharing my data. No, I absolutely don't want you to do that. Not understanding that it may benefit them to share that data, but because there's such a fear of identity theft and your personal information hitting the dark web and whatever, they're just going to say no without even considering it because they don't understand.
I think that gets to the education component as well. Yep. But you're right. I think there's going to be probably a sizable percentage of patients that just say no because they are concerned about their data going where it shouldn't go. So I think very good points, Marilee. Bob?
Yeah, there are a couple of items that we might want to take into consideration. To do an opt-out, you would have to make the assumption that you're operating under HIPAA's provision for care management, which requires that you do minimum necessary. By having the patient opt into the sharing, you bypass that. They're then authorizing the exchange of everything that can be shared. The second part is, while there was a point at which there was a consideration that the patients would do this through an application, the new process is defined as an enrollment process. Basically, when you enroll with the new payer, you tell the new payer, go get my data. And so you have the opportunity to educate the member at that point in time as to what the benefit is, what the information is going to be used for. So there is actually a increased ability for a new payer to go and educate that member to make them understand the benefit of sharing the information with the new payer.
Excellent point. The other point raised in the chat, Celine writes, another question to consider when a patient opts out is, does it mean they're opting out for all means of exchange? And I think it gets confusing, in particular for the patient. There's so many different avenues now, especially with TEFCA and QHINs, local data exchanges. So it's got to be very, very clear what they're opting out of. So very good point, Celine. We'll go to Linda, and then I think we'll wrap up this section. Hi, Linda. You may be on mute. We're not hearing you, so if you can, maybe put your comment into the chat, and we'll try to. Yeah, we've unmuted you, but we're not hearing you. So if you, try again, Linda. Maybe one more time. No, we're not hearing you. So if you can, please put your comment into the chat, and we'll give Sam last word on this issue.
Yeah, I was going to say, I think that we may have crossed many of these bridges already, and there could be some lessons learned that when we needed to do this opt-in, opt-out business in terms of, the information exchanges and the passing of information from the providers up to the information exchange for many of the same reasons, so that it would be available to other payers in an emergency situation and a provider, any kind of information where the information would have been needed on a rapid basis. I think that we've really done that a lot. So might be some lessons learned there to look at that and how that matter.
Appreciate that.
And we do, and we'd have to definitely keep track of it by the information type. So, there's all different classes of information, which I don't need to go through here, but they're already classified by that same regulation. So, you're a behavioral health thing, you're, a family planning type of issue. There are categories that are carved out. So, they have to each have a separate security point.
Excellent points. So Linda writes, how will, very good point, how will minor consent laws be addressed? I think that's another issue. I think that we may want to include in our comment letter to talk, maybe to try to get the government to issue some guidance around that particular area. So very good point, Lynn. Yep, good. I think, Michael, we can go to the next. I think we have got a poll on this one. So very simply, which approach do you most support? Patient opt-in, opt-out, or if you're unsure, or if you have no opinion. So we had a good discussion. It seemed to be leaning one particular way, but I don't want to bias the sample here. Looks like opt-in is preferred, but there's a lot of folks that are unsure. I think, there's a lot of issues around this that it'd be nice to, candidly, it'd be nice to pilot test some of this stuff before it went into to production. But it looks like the majority are saying opt-in. A few suggest opt-out. Again, the opt-out, while it has its challenges, it certainly will engage a larger group of individuals, good or bad. So with that, so I think we can close that poll. Michael, thank you very much, and move to the next slide. So we have a requirement that it impacted payers to request a patient's data from the previous payer no later than 1 week after start of coverage. So anytime there is a requirement for an action to take place, there's always some issues around, is that sufficient time? So let me pose that question again. This is aimed at payers, but interested in anybody who has an opinion. Is that sufficient? Is 1 week enough time to put that request back to the previous payer? Ed, you must have a thought on this.
Oh, I know people take vacations, right? I mean, so 1 week's a pretty short time when it comes to people checking emails and checking their communications. I would think, something more reasonable like a month would be more appropriate. That'd be my take.
How do others feel? 1 week, 2 weeks, a month? Bob? I think you're on mute.
I want to have people keep in mind that one of the reasons they made it a short time frame was to ensure that the new payer had the information to minimize the issues related to transitions of care.
Yep, good point. Janice?
Yes. So I would also point out that this payer-to-payer exchange is the driver for some of the other exchanges. For instance, once a patient is no longer enrolled at a payer, they no longer have to do the provider access APIs or the patient access APIs. So in order for the patient to continue getting any of their existing data, it has to flow from payer to payer. So if there's a long delay in that process, the patient loses access to their data for that period of time.
And Linda does ask the question, is that time from when the data is received or data is processed? Because that's two separate dates. potentially. Ed?
I stand corrected. I see, when it comes to continuity of care, I didn't consider that in my answer. I think that's a much more appropriate.
Well, but the question is, if the health plan is not required to adhere to what the previous plan approved, then I guess it wouldn't matter if it was a week or a month. Correct, Ed? I don't know if they were required to continue the treatment plan, for example, under law, then the timing would be critical. And of course, we do have the payer to provider API, and you would think that that might be a better tool to ensure continuity of care.
Yeah, that's a good point. I defer to Janice. I think she had a good perspective.
And the assumption is that if the health plan received the information, they would act on that information, which they may or may not. They're certainly not required to by law. Back to that continuity of care issue. So interested to hear from last opportunity for health plans to weigh in on Ed's suggestion of 1 year. Oh, I'm just kidding, just a month, or do we do the 1 week? Sorry, Ed, bad joke.
That was good.
Reading some of the chat here. Yeah, so Chris mentions, if it's not a frequent connection, and again, it's not going to be a frequent connection, most likely, there could be a lot of tokens to reauthorize. So, Chris, are you saying that a week is not enough time? Or are you saying that it can be done, it's just not easy?
I understand there's a lot of data and pieces to get going in a short period of time. Saying that with much of this being January 1st type coverage, you've got a lot that has to be moved. Oftentimes you're getting enrollment stuff, kind of late. You're processing. It takes a lot to get done and everything out the door for January 1st. Say ID cards and so on. That on top of that, we got a whole lot of technical stuff. We got to make sure to get everything reestablished between endpoints. Could be a bit of a challenge in that particular time frame. It'd be nice to have a little more time or a little more flexibility on that.
Yeah, and I think, Chris, to your point, I would think that 99% of I shouldn't say that, but a huge percentage of this data exchange would occur from January 1 to January 7. So it's not like it's spread out over the year in a nice, easy to handle approach. It's all lumped into that first week for so many patients. So huge issue, I think. So we'll go Bob and then Ed.
Yeah, I would suggest we consider commenting on it should occur within 1 week after enrollment, and then should occur again 30 days after start for any balance of information that's available. That way, if you've enrolled at the 1st of December, you have the base information that you can use to make decisions well before the plan year starts. Because having a new patient in and discontinuing, for example, something that's been prior authorized, discontinuing medications, requiring somebody to restart on medications that have gone through process of review, step therapy, that's a problem.
Very interesting, Bob. I like that idea about maybe staggering the requirement. Because as you say, at least you would get some of the information that maybe up front, and then you'd have additional time for the remaining information. Is that what you're saying?
Yeah, and also it staggers the time when you ask for it, because, when most of the enrollment periods close, you have a fair amount of time before the plan actually starts. So we can start, instead of doing it over a less than 7-day period, do it over perhaps a 30-day period or more.
Excellent point. Ed, please.
Yeah, quick 2 thoughts. First of all, to Bob, that was quite eloquent solution. I was really impressed with that. Something to call out that Christopher said from a technical angle, I would think most health plans would be connected up to the other payers that they've, typically have people coming from, right? Say someone moved from Oregon, Portland, Oregon, over to Buffalo, New York, Christopher, and you have to go ahead and establish a new connection. Those particular implementation guides aren't mandated. You may have quite a challenge getting that data over to you. And so I wonder if there's some sort of nuance by saying if there's not standard implementation guides that are mandated, should there be some consideration for those sorts of challenges?
A couple of good comments in the chat. Sam writes and reminds us that people change jobs on a regular basis, so it's not just happening on a yearly basis. And Linda writes that this is to be used for information only, not authorization or submitting claims, because there are the 2 EDI transactions under X12 that flow from the employer to the payer. So good points. Michael, I think we can go to the next. I think we've got a poll question on this one. We do. So level of agreement, 1 week is sufficient time to allow payers to complete their process for identifying patients' previous and or concurrent coverage and initiate this request for data from the other payer. So we've got some agreement, but we've got somewhat agree and somewhat disagree. So we've got a mix of perspectives here. I do like Bob's hybrid suggestion. I think that merits something that we should look at closely for the WEDI comment. All right, and so I think we can end the poll, Michael, and we can move to the next slide. So we do have a question on qualified health plans and Medicaid exemption, and there is the suggestion that some of these programs could submit and be granted approval for an extension or exemption as part of the established processes, and they are proposing that these plans would have to submit requirements and include certain documentation. Any comments on this? Anybody feel that these plans shouldn't be given an exemption? I think in particular, I think they're suggesting that some of the state Medicaid agencies could face significant challenges in trying to meet some of these requirements, but it would be a state issued request to CMS. All right, not seeing anything. I think we can go to the next slide, Michael. And Sam, see your hand up.
Yes, I had to wait to get unmuted. I think that there's going to be a problem in terms of the exemptions, because from a discrimination point of view, you basically saying that this extra avenue of benefit to the patient by having the health information record available to whoever their current payer is, and that the history is going to be there, et cetera, et cetera. If you say that the health plan, say New York State Medicaid, but to get an exemption that they don't have to do it, well, that whole group of patients now, which are probably the most in need of something along these lines, is not going to have access to that because the state decided that it's not going to spend the money to become compliant.
Yeah, 100% right. It's tough on the patients that might have benefited from these requirements. So would it be fair, Sam, for WEDI to put in our comment letter that these applications should be reviewed carefully to ensure that there is a sufficient argument from the state that they are unable to meet the requirements of the rule?
Well, yeah, I think that would be a step in the right direction, but I think that it needs to be something more robust to now say, okay, how are we going to keep this equitable, in the law, and from that perspective, to these community of people that have a payer that's decided that they're going to go for an exemption or not do it, or they're going to be late.
Gotcha.
You make the world equal.
Yeah. What about if we put in our comments something along the lines of, in order to avoid this, CMS needs to provide, technical and policy assistance to those states that need it. And because if they say, we just don't have the technical expertise, that could be supplied by the federal government. So that shouldn't be the reason for a state not being able to comply. Bob, I saw you said something in the chat here.
Yeah, sorry, I meant exemption. I believe now, maybe not for QHPs in underrepresented markets, but certainly for Medicaid and other plans, or Medicare and other plans, I believe the only way to get an exemption is to demonstrate that you have less than a certain percentage of the population. I think it was 10%.
Okay, that's a good point. Good point. All right.
Now,
Michael,
that
I
still
think
creates inequities. Don't get me wrong, but
correct. Yeah. But again, as the rule says, the question is it it's the cost benefit analysis. Is it expensive and therefore not worth the investment? But Don, you got a comment on this? Welcome, Don. Yep. You may be on your own mute. We are not hearing you. Yep, she's unmuted. If you can, maybe make your comment in the chat. I apologize. And Mike writes, exemptions should be time-bound and not permanent. Yeah, good point on that one. So it shouldn't be a blanket. Don't worry about it. And even to Bob's point about the threshold, those numbers could change within a state. So just because they didn't meet the threshold today, that's not to say they don't meet it in 5 years or so. And I apologize, Don, we're still not hearing you. Yeah, sorry, Bob.
I think there's some language in the preamble regarding that. You might want to review it, meaning the need to re-up or requalify.
Excellent. I think we can go to the next slide. I think we may have a poll on this. So again, they are arguing that promotion of health equity can occur through the patient opt-in versus opt-out. So we'll do a quick poll on this, and then we'll move on. Oh, I see Tammy. Welcome, Tammy. While we're doing the poll here, Tammy writes, could you add to the previous discussion, payers submitting a rationale to not be subject to the rule must provide substantial rationale to offset the negative impact to a vulnerable population. I think that also arguably gets to their issue of health equity as well. So I think what Tammy and others are arguing is, in particular, the vulnerable population is going to benefit from this exchange of information. So there better be a good rationale for not being able to comply with the law. Okay, I think we can close that, Michael, and I think we can go to the next slide. Let me just read Don's comments. Sorry that we couldn't get you on here, but it is not a permanent exemption for Medicaid. The exemption was instituted to allow states flexibility as a result of the PHE and the redeterminations. There may be other issues as well. Well, correct. However, the PHE is going to end in May, and this is going into effect several years from now. So, yeah, I think I'm hearing, generally speaking, that WEDI should be encouraging Medicaid plans to support this. Exemptions are necessary, but they should come with some pretty stringent requirements. And again, maybe CMS can offer tactical and other support to help those states that are struggling. I think we can go to the next slide, Michael. All right, and the question is applying this to Medicare fee-for-service. And so we'll open it up. Any thoughts on whether or not Medicare fee-for-service should be one of the impacted payers? Ed? Yep.
I'm wondering if I'm trying to recall back when we had the original interoperability and they made the justification not to cover Medicare fee-for-service is that they had something similar already. And so I'm just carrying forward those thoughts by saying that might be the same rationale here.
Good point. Yeah. Anybody with any thoughts on this? All right, Michael, I think we go to the next slide. We have a poll on this one. Sam, please. Yep. While we're doing the poll. Yep.
I have a concern about the definition of this, because right now, there may be post-audit reviews in terms of medical necessity and through the contractors, but for the most part, Medicare does not impose a, utilization review component to their plan, and that's what makes it primarily a fee-for-service plan. That it's a not a nurse sitting in an office somewhere looking at a standard that says, okay, you had 2 from this row and 3 from that row. And so your care is eligible and somebody else's is not. I just want to make sure that what this isn't leading to is for them to say that Medicare Part A in particular is now subject to the same type of utilization management that is part of a Part C plan. So that in other words, that when you go into a Part C plan, like any type of managed care plan that's covering Medicare patients, you're automatically subjecting yourself to a justification to a agent to say, why do you need this case? Why do you need this done? What is it going to do for you? Convince us that we should pay for it.
Good, and you're thinking that this going down this path might encourage additional requirements on Medicare fee for service.
Yeah, well, we understand that underlying here is you're asking that clinical information that would not currently be shared today is made available to yet another source that is going to do whatever it's going to do with it.
No. Thank you, Sam. Michael, I think we can go to the next slide. Okay, we can close that. So they were pretty adamant about the requirements not applying to drugs. And it also, they talked about this in the prior authorization component of the rule. So there is an argument that drug information is helpful. So I guess the question is should the rule expand to include drugs? Obviously, it has some implications. Janice, I see you've got some comments here. Drugs are only exempt from the prior auth pieces, correct? Not from the other data. Good. Oh yeah. Okay. Michael, if you can unmute Janice. Thank you.
Yes, this is Janice Karen from MHGC again. It's my understanding that that is very specific to the prior authorization components. And in fact, if you think about it, medications are a part of US CDI. And US CDI version 1, which is part of the clinical data requirements for all of the data exchanges. So perhaps I misread, and if I did, please point that out. But my understanding was that all of the drug comments were very specific to all of the prior authorization clauses.
That's a astute point. I appreciate that. All right. So let's go to the next slide. I think we have a poll on this. So let's. So should the requirements for payer-to-payer exchange include information about prior authorizations for drugs when the payer covers drugs? Looks like we've got, generally speaking, yes. We've got a couple of no's, some unsures. Pretty strong support, though, for yes. So. Interesting. Okay, I think we can close the poll, Michael, and go to the next slide. We've got a few slides to go, so we're trying to get through it fairly quickly here. So we're going to move on to the patient access API. Bob, I don't know if you, first we got Ed and then Janice again.
Well, I just wanted to slow you down, Rob.
Okay.
Yeah, Janice, I hope you can get off on mute too. I just looked up on my notes. It looks like they are excluding drugs on the prior authorization. And my perspective is probably they're just trying to keep those two parts of this within the same rule together between the prior auth and the patient access. I know, are you seeing the same?
If you're asking me,
yes.
My expectation was that drugs in general were covered, just as they are, for instance, in the existing May 2020 rule for the patient access API. Drugs were included there, and that we're not taking that data out now. We're just not doing it for the prior auth, but
just not doing
like
it for the prior auth. Yeah. Not doing it for the prior auth. That's correct.
Yep. Can I go on to one last quick point before we move away from payer to payer? Because you didn't raise the thing that I thought was most interesting. Okay. And that is that they have a requirement in there that says that payers are required to support their end of the transaction, regardless of the status or applicability of the rule to the payer on the other side of the request, which, if you think about it, is somewhat problematic, because if a payer that's covered by the rule receives a patient request to retrieve the existing data, but the old payer is not covered by the rule and hasn't implemented it optionally, what do? Because there may not be a FHIR endpoint on the other side for them to make the request for. So I think that was one of the things that really stood out to me when I was reading the rule for payer-to-payer as something that needed additional clarification.
And it, of course, it applies for our previous discussion about those plans that are exempted as well. So
That's
now
right.
yeah, good, very good point, Janice. We'll go, Bob, you may have some thoughts on this.
Well, I got the impression, and I'd have to go back and reread it, that the intent of that comment, and I agree with you that it's an issue that needs to be addressed, was that if you're a covered entity, you can't tell someone who is not a covered entity they cannot come and get the data. So it was more on the ability to move it, for example, from Medicaid to commercial than it was to go and say, what happens if I want to move it from commercial and they don't support the API? Maybe I'm wrong, but that's the way I read it.
I don't know, Janice, if you want to.
Yeah, I thought they explicitly called out both cases. So
they may have, and I may have focused on the one that I understood the best. So.
Right, because it obviously makes more sense in the case that you're talking about. There's an obvious path for doing that.
Yeah.
But
we may want to comment
case,
on that.
Indeed.
Yeah. Yep. That's a good.
That's point. Why I raised it. All right, I'll let you move on because I know time is short.
Ed, I don't know if you have a comment.
I'm just saying, I just wanted to, if you're talking about the patient access, there's certainly drugs and formularies, EOBs in the clinical perspective, is just not in the prior auths, which I think that's what Janice originally said, but I wanted to state, I think the reason for that is because it wanted to be parallel to what they were saying on the party stuff.
Good, and Janice says yes to that, so good. So Bob, you want to walk us through the patient access API?
Sure. But let me make a comment on the drug issue. My understanding was they excluded drugs from prior authorization because drugs prior authorization is already covered under a separate regulation and is done through NCPDP. Oh. So they were trying not to create two conflicting channels. The problem is they said all drugs, and not all drugs are covered under the, if you will, NCPDP channel, in particular, those drugs that are part of a medical benefit or part of DME. So we have a gap there, and we probably should comment on that they should be talking about only drugs that are covered under, if in effect, a Part D benefit.
Good point, Bob. Thank you.
And I agree, all drugs have to be exchanged. It's only about prior authorization. So you want me to walk through this?
Sure, that would be fantastic.
Patient Access API. What they have done is they basically taken the Patient Access API rule that was previously finalized, and they've added into it the requirement to exchange prior authorization information. They've been very explicit about what the elements are. One of the most complex elements is use to date. So in other words, the payer's experience on the amount of something that has been used. You have 20 home healthcare visits, you've used 15. You have 12 PT visits, you've used 6. So there's a utilization requirement, which makes it a little bit different than the normal exchanges for prior authorization. And that's what PDEX did, was it used the EOB, which allows us to go and include information on utilization to date. It seems to make sense. The complexity is whether payers can pull that information together in a reliable way, given that it won't necessarily come in from an automated prior authorization transaction.
Very, very helpful.
There's only one. There's one other point. I'm sorry, I forgot to mention, and that the Patient Access API. Let's see. I'm not sure about that. Okay, the Provider Access API. You got these two combined together. The Provider Access API does not include information regarding payments and cost sharing, but the Patient Access API does include information regarding costs and encounters.
Good point. So I know, Michael, if you go to the next slide, I think we are asking the question. Let me see here.
Are we doing provider access or patient access here? I think the last one said patient, didn't it?
Yeah, I think it should say patient. Yeah.
Oh, this, or should it say provider?
Yeah,
providers are more complex problem.
Yes, for sure.
This is a provider access API slide. You want me to cover that one?
Yeah, that'd be great, because I think we're quickly running out of time. There's a lot to cover here, obviously.
Provider Access API, what they have done, and this comes out of the 2020 December NPRM that never made it to a final rule, was to require that payers share information with providers for their covered panel. In other words, the panel of patients that are being covered by that particular insurer. This was to propagate what CMS has done with fee-for-service in their data at point of care program. And so what would be done is to create an attribution list that basically says, hi, these are our shared patients, okay, or members, depending upon which side of this you're on. And then have the ability to request information on any or all of them using FireBulk, for example, to go and allow you to exchange information on a large number of patients. This program is an opt-out program, not an opt-in. And the reason it's opt-out is because this is intended for treatment and therefore is an exception under HIPAA and doesn't necessarily require the patient's consent to have this happen. The patient will have a right to say, don't do it. The requirement in the NPRM at the moment is that you have to opt out of everything. A payer must support the ability to opt a member out. But they have encouraged it to be done at a more detailed level where you could potentially opt out of sharing information with one provider, but not another provider. That covered enough or not?
Yeah, no, that's excellent. I think we can skip ahead a little bit, Michael. I think we can. So let's maintain that one. I think we can. We've talked about this a little bit. Maybe just real quick on the 1 business day requirement to move the data to the Patient Access API. Again, I want to hear in particular from health plans how challenging that requirement is to move that data within 1 business day after the claim is adjudicated, or clinical encounter or clinical data are received by the health plan. Any thoughts on if that 1 business day requirement is sufficient, Sam? Yep.
So I think that, that's it says 1 business day from the claim adjudication date, which is correct. Very different, and, might not happen for months if it after the service. So, I go back again from an expectation. It's great that you're going to get it 1 day after the claim's paid, but, the patient died 6 months ago. So again, what relevance does it have?
Yeah, I'd be interested to hear from the plans. Yeah, I mean, that's, again, sometimes it takes, months to get the claim submitted, and then it's a certain amount of time. Even in prompt pay states, it's still a couple of weeks. So just because it's 1 business day after the claim is adjudicated, that's not to say that the information is quickly entered into the API. So other thoughts on this? Worth us making a comment, Ed? Yep.
I'm just saying that this is most likely, this is consistent with the first rule, right? The original rule was 20 or next day for clinical data and for EOBs, like, and as Sam said, after it was adjudicated. I think the area we should probably focus on is prior auth status and getting that out there in one day and how hard that would be. I'm curious to hear what health plans have to say about that.
Yeah, that's a great point. So Janice writes the threshold mentioned in the PA specific, the rest of the data. Yeah. So from all our health plans here, or Mike, please.
Yeah, I just wanted to share that oftentimes a patient will not know when a claim has been adjudicated, and often with claim processing, it could be that some services were paid and some were not. So, you know, it could be very confusing to a patient, one, to know when they can access their information, and two, why their information is potentially incomplete.
Yeah, if they're expecting the information to be in the app, you know, as soon as they go home from seeing the physician, that's not going to happen.
Right.
Yeah.
And they certainly don't know when the actual adjudication and payment occurs. That's not, they're not privy to that knowledge. They're not part of that workflow.
Excellent point. Any thoughts on Ed's issue about prior auth status? Anybody have any comments on that before we move on? All right, Michael, I think we can go to the next slide. And we do have, now, because it's adjudicated, this may not be as applicable, but is 1 day still reasonable, or should it be longer than 1 day? Okay. Good point, Janice, that it's jives with the current rule. Yep, we're not asking about PA here, correct? So pretty mixed. Most are saying it'd be nice to have a little bit longer time. 1 business day does seem rather quick. Okay, I think we can close the poll, Michael, and move to the next slide. Now we move on to prior auth information. Here's the 1 year issue that Janice raised in the chat. Be available via the patient API for as long as the authorization is active and at least 1 year after the last status change. Any issues with this 1 year requirement? We'll give it just, yeah, and Janice raises a good point. It applies to both the patient access and provider access APIs, so good point. All right. Question, Bob, you got, Sam, please, first, yeah.
Yeah, just real, I don't think that is something that is can be said here, because you know, the record retention rules about, you know, how many years you need to take information and keep it are different based on the state requirements.
Yeah, correct me if I'm wrong, Sam, but wouldn't the state, generally speaking, be something like 5, 7, or 10 years?
Yeah, that's one way that they've done it. But, you know, legally, I think it's, you know, for any kind of audit purposes, it's 24 months from the date that it's 6 years from the date that the claim was adjudicated. So up to you know, I was there in January of 2001, and it's now January 2002 when my claim first got paid. I have to keep that data around for another 6 years after that.
Gotcha. Yep, good point.
Anything related to pathology data? meaning, true surgical pathology, that's 20 years.
Wow. Okay. Good to know. I think we can go to the next slide. I think we've got yeah, so here's where they're saying, let's go back. So they're making available any of the applicable patient data with the data service on or after January 1, 2016. So that's by the time the law goes into effect, that will be 10 years. Any issues? And as Janice says, again, it applies currently. So any issues that health plans have found, this might be an opportunity to tweak this proposal from CMS. Any health plans finding that to be a particularly challenging requirement? Not seeing any come through. I think we can go to the next slide. It might be a poll. And Chuck says, should this be a rolling 5-year requirement? So let's get a sense from our participants if the January 2016 date, so the 10 years in 2026, or should it be earlier? Should it be later? So it's a mixed here. Date is correct. Seems to be leading the race. And should be later as well. We're hearing from folks saying that. So only one is saying it should be earlier than 2016. So, and again, Janice says it might be easier for the payer, but less advantageous to the patient. It's a good point. Ed, sorry, go ahead.
Yeah, I think at the end of the day, we should ask this question 4 years ago, because the parents I work with, right, they had a struggle. They had multiple adjudication systems. They had to reach out to the PBMs. It was the clinical records are spread all over the place, and it was hard. But I think once you've accomplished it, it's there. So that would be my play.
Great. And Michael, I think we can go to the next slide. So this is maybe it might be the last major topic we discuss here today, and that is, of course, the metrics that plans would be required to report. There's a pretty sizable section of the rule that discusses this. So they want to know how things are going. I think that makes a lot of sense. I guess a question would be, should WEDI say, use those statistics, those metrics that you receive in an actionable way? So if you find that patients either aren't aware or they're not, payers are having challenges trying to meet the requirements, that might be an opportunity to take action. Janice?
One thing that I noticed about the different reporting requirements that I thought was interesting was that they vary from section to section as to whether they're public or private, whether they're posted on the website or sent to CMS. And I think having, unless there's a real rationale to not do it that way, I think having some consistency around that might be helpful, always doing that the same way.
Yeah, and there's some precedent as well, of course, with the Sunshine Act and requirements on various provider entities to report various financial metrics. It is, these databases are public. That's not to say the public is aware of them, but they're helpful in maybe a small number of cases. So any challenges to this? Any health plans feel that what CMS is proposing is going a little bit too far? Chris, I don't know if you want to talk a little bit. You say, not sure the patient access multiple polls gives much good data, since an app could automatically query, which does not mean the member is actually using the app. Well, A very good point.
Yeah, that's just one of the things. It's hard to tell. It looks like they're looking to say, well, is somebody actually interactively using this? A query doesn't mean that multiple queries doesn't necessarily mean that they're actually using it. It could be a setting in an app, and maybe depending upon how the fire resources are counted, is each one of those a multiple pull? It's hard to say based upon what they're asking for, how you count for it, and does it actually give any real useful information?
Would Chris, let me push you a little bit. Would it be a comment from WEDI that maybe CMS engage with some patient surveys rather than going to the payer, go to the patient and find out how and if they're using these apps? Sort of a national survey that might be more accurate, correct?
It could be. I mean, for the covered population, they probably have some manner of accessing who all the members, Medicaid, Medicare, CHIP, those things, and the QHPs are to be able to directly ask them, since those are the covered member people, as compared to trying to do a general survey across the country.
Gotcha. Yep. Bob?
It might be worthwhile keeping in mind that the payers will always have an idea of how many apps or individuals have accessed the record. I agree, it may not be clear how many have accessed it multiple times. Maybe that's where the clarification could come in. And really the question would be on different dates. And yes, it might be that the application's set up to do that, but that's something we can't control. So at least you could avoid the issue of accessing different resources.
Well, would it be fair, Bob, for WEDI to say something along the lines of, be wary of the data you receive, because it may not be fully indicative of what's happening out there in the real world. So to the point that Chris and you made, there may be an automated approach that sort of gives the impression that patients are getting access, but really it's just the app that is downloading the data.
Sure.
So be careful what you receive, I think is maybe the point. Ed? Yep.
Yeah, I think Christopher and Bob made some really good points. I'm just looking at maybe the original intent, because so many people download apps, they use it once and it sits idle. And I think maybe a better question is if that's what you're getting after, perhaps, are you looking at it over multiple days, or, getting to what Bob just said, to be able, to get to because, as Christopher says, if it's downloading every 10 minutes, it's going to, misstate the real use.
You could track if that application for that patient has reauthorized for a token, because the token grants right now, I believe, are for 90 days. So if I'm really using the app, I'm probably using it for more than 90 days, which means I have to get a second token.
Mm-hmm.
I don't have a choice.
And Celine writes, done correctly with education, these data points will be valuable in helping patients and the public understand their ability to access their personal health information. I think, the key word there is education. I think that's what I'm hearing throughout this event, is that we really need to educate the patient, because that's the only way that these numbers are going to mean anything, if we get the numbers high enough, but also to query to make sure that the data flow is going well. Janice?
Yeah, since we're on the topic of education, I want to point out one other area where education could be helpful. One of the pieces of feedback we got from the original patient access API was that payers weren't necessarily implementing them or doing the things that made it possible / easy / useful for the apps to connect to them. So the payers would put up the API, but wouldn't necessarily have a consistent way that they're putting the data in, or where they're handling how the auth tokens get passed, or have a consistent mechanism for finding the endpoints or doing entry. I don't remember. There was probably a dozen things that some of the third-party apps have talked to us about that caused them problems when trying to use patient access APIs. And when we talk to payers, they're sort of a, if we build it, they will come attitude, and there's some disconnect there. So I know it's a little bit outside, but if we're talking about looking at usage and how we can determine, that's the component of it, that level of education of, and I'm not sure exactly how to quantify that, or exactly how that happens, or what the right mechanism for pointing that out is, but that's one of the disconnects that's in the existing patient access API.
Excellent points, Janice. Ed?
Yeah, just want to make a suggestion. Since we only have 5 minutes left, I would love for you to have some feedback regarding provider access and patient attribution. I think that'd be a really good topic to cover real quick.
Yeah, agree. So let's skip down some slides, Michael, if you don't mind. Keep going. We'll skip these here a little bit. Okay. Keep going. Way down, I think. Yeah. Okay. So we'll go back one. Let's do the patient attribution, because I think that one is a little bit of a challenge. I don't know, Bob, if you want to, if you're able to talk to
Sure.
The attribution issue.
This really stems from what CMS did under the data point of care. They created the idea of a shared attribution list, where based on the fact that they got claims from a provider, or a provider declaring that they were treating their patient, they had a shared list that they could then request all the information from Medicare fee-for-service. What they're doing here is they're saying they need that kind of an attribution list between a provider and any of the covered payers to be able to define those members that are being treated by that payer or by that provider, and therefore be able to go and have the provider ask for updated information on all of them or any one of them. We have a mechanism with Da Vinci of something called an attribution list that could be used. I think it's mentioned in the preamble as a basis for creating that shared list. Part of the question we have is, how do you deal with brand new patients? Somebody just schedules an appointment. Okay, is that evidence of the fact that they are now have a treatment relationship? If so, we have to have a way to add them to the list. So there's some gotchas in that attribution list.
Janice? Yep.
And I would argue that it goes beyond that, because just because a patient sees a provider once doesn't mean that they have an ongoing patient relationship with them. That doctor may not have worked out for that condition. It may have been a one-time thing, and they don't necessarily want or need that provider to have their data. So I think that there needs to be some type of actual relationship mechanism that isn't just there's a single visit on the book somewhere.
That's the hard part. And there is an opt-out capability. And if you turned around and implemented as a payer on a per provider basis, that would at least address some of your concern. I don't know how you maintain a, do you have an active relationship? I mean, I've got providers I go see once a year. It doesn't mean they shouldn't have access to my data in between.
That's a fair point, but I believe that the current requirement is fully opt-in or opt-out. There was some discussion of having more granular. Maybe I'm misremembering. It's getting late.
No.
And we've talked about a lot of stuff.
It is automatic opt-in because it's a treatment relationship.
Right, but with the option to opt out, but not at a granular level. They talked about supporting it at a granular level, but I don't think they said it was required.
That's correct. The payer is required to support it at a macro level. They encourage the payer to support it at a granular level, but don't require it.
Yeah, but I think Janice's point that you may have a condition, God forbid, and you have a dermatology visit. It's a one-time, and you may never see that provider again. And that applies a lot. Or again, you go to see one, you don't like them, and it's a one-time visit. You go somewhere else. Janice?
Also, I almost forgot my favorite use case, which is getting an independent second opinion. I can't believe that. Not being able to do it more granularly makes that really difficult. It's bad enough if you're in the same system and they automatically get access. But if you go in, wait a long time for a second opinion, and you get there and they've seen stuff that isn't giving them an independent view because they've read 8 gazillion notes from other people's opinions, it's kind of wrecked the point of having that appointment.
Good point. And
so that more granular, I would argue pretty strongly for requiring some level of more granular opt-in, opt-out.
Excellent. Ed, we're going to give you the last word here.
Oh, thank you. First of all, I want to appreciate Da Vinci's work on trying to address this issue. My concern is education, right? I mean, a lay person who doesn't live this world have an understanding how to do it, or is actually enabled to do it through their apps or through whatever mechanism you come up with. So I think education really has to have a big play here as well.
Good. And with that, we did not get through everything, but that's not necessarily a bad thing. The fact that we had such robust discussion was not only interesting, but extremely helpful for WEDI as we develop our formal comments. I don't know, Ed or Charles, if you wanted to say any last words before we close.
I'll defer to Charles since I've been talking a lot. And if Charles is not going to speak, I'll speak.
Okay, please, Ed.
Yeah, I hope this has been valuable for everybody, and I encourage you to provide feedback to us, through your WEDI staff, or personally to me, or to Rob, or to Charles, or Michael, or whomever, to be able to tune these processes where you're getting the most out of them. I'm hoping that you got a nice educational perspective on some of these topics, and you're hearing some of these issues that are being addressed differently, but also let us know how we can improve the process. But appreciate everybody's commitment. We still have 55 people signed on. That's quite a commitment to make it all the way through here. Thank you so much.
I was very impressed. Last 2 things I'll remind folks: we have 2 more MPAs next week, and again, it is raining regs. There is no question about it. So we're going to talk prior auth on the 28th, and then 2 days later on the Thursday, we'll talk about the attachments NPRM. I wanted to say a special thanks to the facilitators, Ed and Bob, fantastic work, and extra special thanks to Michael McNutt for his wonderful work behind the scenes to make it all work smoothly. So with that, we'll close out, and I look forward to speaking with you all next Tuesday. Have a good weekend.